buenas tardes a todos. Muchísimas gracias por acompañarnos hoy en este día tan especial.
Oye.
Queremos pedir, por favor, que pongan en silencio sus micrófonos para no interrumpir a ninguno de los panelistas. Usualmente, si se les desactivan, por favor, volverlos a colocar en silencio, ¿ok? En el día de hoy vamos a tener una dinámica distinta a la que hemos hecho anteriormente. Vamos a presentarles sobre quiénes somos para los nuevos, porque tenemos personas nuevas en el día de hoy. Les voy a compartir mi pantalla unos minutos y para que puedan entonces saber quiénes somos celíacos PTY, ¿ok? Primero, pues, muchísimas gracias. Nos honran con su presencia aquí por sacar un tiempo, un viernes a las 3 de la tarde. Sabemos que es caótico para todo el mundo y aún así están aquí. El día de hoy, pues, tenemos el webinar magistral con el doctor Alessio Fasano. It's an honor to be here with you. Thank you very much. Así que les vamos a hablar un poquito sobre quiénes somos, ¿no? Nuestra historia juntas, pues, Rocío Vidal, que es mi persona, y Catherine Chahani, ambas somos pacientes diagnosticadas con enfermedad celíaca, Katy desde hace 3 años y yo desde hace ya 6 años. Nosotros nos conocimos en la Fundación de Celíacos de Panamá, mientras estábamos apoyando un poco a la fundación, y luego cayó la pandemia y empezamos a hacer esta edición, la primera edición de Live y Webinars, dedicada para ustedes, querida audiencia, y luego ya tenemos el segundo año, y aquí estamos pues con un webinar magistral. Katy Chahani es conocida en el medio, ella es Healthy Coach, es la creadora, la CEO de Ladies Sin Gluten, 3 años padeciendo enfermedad celíaca, es la fundadora de la primera escuela sin gluten en español en Panamá, y pues sabemos que tiene su libro de Balance de los Malabares, que es una belleza. Casualmente el día de ayer estábamos en una firma de este libro, y por más de 20 años ha trabajado en real estate aquí en Panamá. Por mi lado, pues yo soy Rocío Vidal, la cara detrás de Sintagma y Hla Test, cuenta creadas hace 5 años atrás para crear conciencia sobre la enfermedad celíaca. En estos momentos soy Wellness Advocate en doTERRA, me va muy bien, me encanta, soy feliz, y antes de esto pues trabajé por 15 años en finanzas y marketing en la empresa privada, madre de una pequeña de 2 años pues y feliz esposa. Nuestra visión en Somos Celíacos PTY es más que nada crear esta conciencia primaria sobre la enfermedad celíaca, ser una fuente de comunicación para ustedes y para todas las personas que son recién diagnosticadas o que sufren de alguna alergia, intolerancia, alguna enfermedad relacionada al gluten. Nuestra misión es evitar que hayan diagnósticos errados y que las personas se quiten una dieta sin gluten sin tener un diagnóstico. Obviamente todos queremos tener una calidad de vida, pero nosotros no somos nuestros propios doctores. Tenemos que aprender a escuchar nuestro cuerpo e ir donde una persona especializada, entonces podemos tener un diagnóstico y allí podemos hacer cambios en nuestra vida. ¿Ok? Queremos siempre agradecer a nuestro panel que nos ha acompañado durante estos 2 años, las nuevas personas que se integran, el doctor Carlos Retalis, que siempre ha estado de la mano con nosotros, igual que la psiquiatra Alicia Rego, y este año felices de que se sume a nuestra causa la doctora Anet Zamudio. Y sin más, Katy, te dejo a ti para que puedas contarnos un poquito qué hicimos el año pasado y lo que estamos haciendo en este tiempo.
Sí, ¿qué tal? ¿Cómo estás, Catherine Chahani? El año pasado tuvimos el Season 1 con 8 episodios buenísimos, donde tuvimos especialistas que nos hablaron sobre la enfermedad celíaca en diferentes aspectos. Y este año en particular ya tenemos también otros 7 episodios. Casualmente mañana finalizamos con el último, donde tuvimos enfermedades relacionadas a la enfermedad celíaca con sintomatologías que a lo mejor no estamos uniendo, que tienen que ver mucho con el diagnóstico de enfermedad celíaca. Lo importante que veamos es que siempre estamos rodeados de especialistas médicos de unas fuentes fidedignas. El día de hoy tenemos la oportunidad de contar, tenemos la oportunidad de contar con el doctor Alessio Fasano. Alessio Fasano es un gastroenterólogo pediatra que fue el que descubrió la existencia de la sonulina, que es la causa del intestino permeable, y también hizo comercializar la prueba de anticuerpos de transglutaminasa, lo cual nos permite tener un mejor diagnóstico el día de hoy para aquellos pacientes con posible enfermedad celíaca. La oportunidad que nosotros tenemos de tener al doctor Alessio Fasano aquí con nosotros es realmente impresionante, es un honor tenerlo con nosotros. Él va a dar el webinar en inglés y nosotros pues vamos a poder hacer preguntas y respuestas a través del doctor Carlos Retali, que es gastroenterólogo y parte de nuestro advisory board, que va a poder entonces filtrarle las preguntas al doctor Fasano de acuerdo a lo que vaya hablando en su charla magistral. Así que sin más, yo los introduzco con el doctor Carlos Retali, ya conocido en Somos Celíacos PTY y definitivamente un gran gastroenterólogo aquí en Panamá, que nos va a hablar un poco más sobre este webinar magistral, y un honor tener al doctor Alessio Fasano con nosotros. Welcome, Dr. Fasano.
So, Dr. Fasano, we're going to kick off your this webinar. We've introduced you. It's an honor.
I understood everything, actually.
So there you go. Para que sepan, el doctor Fasano habla español. Siempre y cuando se hable un poco lento, él entiende perfectamente. Así es que, sin más introducción, doctor Fasano.
Sí, claro. Muchas gracias. And again, apologies to speak in English, but if I speak Spanish, we'll be here for 2 hours. So you need to give me permission to share the screen. I don't know who you guys should give me the permission to do that.
Already on.
Otherwise, I cannot share my slides. Anyhow, yeah, oh, wonderful. Okay, I'm assuming that you see my share screen now, right?
Yes. Wonderful.
So once again, thank you for the kind invitation. It's said that, we have to do this remotely, but I hope that, time will come that we will be able to be in person, and I will be physically in Panama. I've been a long time and I've been there, so it will be great. So I'm going to give you a very quick overview of celiac disease, some new stuff that's going on that's, guide new diagnostic and treatment, possibly prevention strategies. Let me start by saying that even your association now, it is my understanding that not only you care for people with celiac disease, but with other gluten-related disorders. And it's been a very interesting phenomenon, starting with increased awareness of celiac disease in the United States and worldwide, that the popularity of the gluten-free diet really increased. And if you ask, people that they go gluten-free, why do you do that? There is an interesting division of what is, this, cake of the cuts in the little pieces. The vast majority of people that go gluten-free, they do that because they believe that it's a healthy diet. Going gluten-free is healthy for everybody. There is another good 25% of people that go gluten-free because they believe that going gluten-free, they will lose weight. And we know that that's not exactly true. Those two categories are the ones that we're not very interested in, but the last three are the ones that are really pertinent to our discussion. There is roughly, 9 million out of approximately 100 million people that go gluten-free in the United States. They do so because they have GI symptoms. So in other words, that if they don't go gluten-free, they have gastrointestinal problems like stomachache, diarrhea, and so on and so forth. Another 7 million, they go gluten-free because they have extraintestinal symptoms that will not go away if they don't go gluten-free. And the small part that you can barely see here, of now shy of 500,000 people in the United States, they go gluten-free because they have celiac disease. And, this popularity of the gluten-free diet has been increasing over time since the mid-2000s, where, the low-carb diet was more popular than anything else. And now, the gluten-free diet is as popular as the gluten-free diet, the low-carb diet. But all this to say that now we talk about a spectrum of gluten-related disorders. The one that they go gluten-free, not for medical necessity, because again, they believe there's healthy diet or because, you know, they think they lose weight. That's not something that we care about. But your association is more focused on who needs to go gluten-free for medical necessity. And you heard, you know, very briefly that you can have an allergy to wheat, so you can have, you know, an allergy to any foodstuff, including wheat. And then, you know, you can have this other form of gluten reaction that we call non-celiac gluten sensitivity or gluten sensitivity. But today we're going to focus on celiac disease because it's the main reason why I was asked to give this chat. If you want to know a little bit more about this gluten-related disorders, this is a good review. This is very technical, so it's more for healthcare professional. But you know, if you read it a couple of times, even as a patient with celiac disease, you may get some hints of what's going on here. To talk about the new diagnostic and therapeutic options for celiac disease, we need to review a little bit about the pathogenesis. So in other words, why people that come down with this condition. And, you know, for many years, we didn't even know if this was a food sensitivity, a food intolerance, whatever. But now we know that this is truly an autoimmune disease. It's like having diabetes, multiple sclerosis, and so on and so forth. And as such, at the beginning, we thought there was a recipe with two ingredients, genes and environment. But even within this paradigm, celiac disease is one of a kind. Why? Because genetics, it's unique in the sense that it has a high penetrance of some genes that the class HLA, class 2, mainly DQ2, DQ8, without which pretty much you can't develop the disease. So that's one peculiarity compared to other autoimmune diseases in which there are similar genes, but you know, 60–70%. Here we're talking about 95% plus. The autoantigen is known. There is this enzyme that we call tissue transglutaminase, or TTG for short, that we use for diagnostic purpose. But what really sets celiac disease apart from any other autoimmune disease is that the trigger is known, that is gluten. Of course, so much so that going gluten-free, if everything goes the way they're supposed to be, because you subtract one of the two key elements of the recipe, you know, the symptoms will go away, the insult to the gut will go away, and the autoantibodies will go away. So the paradigm, the initial paradigm is genes plus gluten makes you to develop celiac disease. And therefore, when you take gluten out, the celiac disease will revert back to a normal intestinal mucosa and, you know, with resolution of symptoms. So we really believe that this was the paradigm. The genetics. So several genes are involved. The most frequent, again, as I told you, is the HLA. But they account for a vast majority of genetics, but the 60%. But there's this 40% of genetic inheritability that we didn't know what was this all about. Then you know, techniques became available, and like this, you know, possibility to look at the entire genome of the human beings and doing some specific studies. And we have been finding genes in several chromosomes that are related to celiac disease. We start with 2, then we went to 10, and then we end up, you know, with almost 50 genes that were found everywhere on the chromosomes. But again, each of them, you know, accounted for very little. Then the technique and the, you know, possibility to look at the entire human genome, so the entire 23,000 genes, allow us to do studies that were unthinkable before. So we can take a biopsy on an individual with celiac disease and look at the expression of all the genes. And, you know, if you see the genes of normal people, the one on the top here, and you compare to one with active celiac disease, we see different colors. You know, blue means that the genes is suppressed, so it's not expressed. You know, maroon, it means that it's expressed too much. Bottom line, there are a lot of genes that expression that changed from celiac disease to controls. And when you go gluten-free, an individual with celiac disease will look genetically much more similar to a normal person. Then we went to the next step. what these genes they do for living. In other words, what kind of function they control. And here, not having an animal model, we had to rely on new techniques that we developed recently, thanks to the contribution of people with celiac disease. One of them is one of yours that was telling me before that when she came to United States for the endoscopy, she donated, a biopsy that now is being used for gut organoids. And this is an example of what we were able to. We found now something like 500 genes related to celiac disease. And the function that they do makes a lot of sense for what we know why people come down with this condition. Some genes that control the immune response. And again, celiac disease has been an inflammatory condition. Of course, you would expect that immunity is involved. Some control the stem cells. They are the cells that they reproduce all the time to cover the intestinal surface. Remember that no matter how old are you, your intestine is always 1 week old because every week we change the entire layer of cells. And there are defects in people with celiac disease in that capability to rejuvenate the intestine. And finally, gut barrier. So in other words, genes that control the liquidness of the gut that seems to be involved in celiac disease. These are genetic. What about the environment? Well, we didn't know anything about the environment until we're, 70, 80 years ago, thanks to this gentleman here. This is a pediatrician from the Netherlands that during World War II made a very interesting observation. That, celiac disease at that time was mainly a pediatric condition with a high mortality. 30% of these kids will not make it, will die. He noted that the mortality went to 0 during the war and came back to 35% after the war. And he reasoned what was missing during the war that now we have again. And he thought, well, grains, wheat was not available. So he did an experiment on 6 kids that before that, the only thing that these kids with celiac disease were allowed to eat were bananas. That's the reason why they were called banana babies. For months, they were fed only bananas, hoping for the best. But what he did, took 6 of these kids and put on a gluten-free diet. They resolved the problem, then put them back on a regular diet exposed to gluten so that the problem came back. And that's how he connected gluten with celiac disease. And that has been the cornerstone of treatment ever since. So the grass family to which, the gluten-containing grains belong to, mainly wheat, rye, and barley, are the ones that are offensive for people. Now, these paradigms, genes plus environment, necessarily sufficient for the condition, they really start to have some issues in terms of, not being supported by the facts. For example, you would expect that if genes plus gluten are necessary sufficient for celiac disease, you would expect that 100% of identical twins will have concordance in terms of celiac disease. That's not the case. So in 25%, so 1 out of 4 identical twins, there are cases in which one twin has celiac disease, the other one does not, despite that they have identical genes and despite they both eat gluten. There are differences of age onset to celiac disease. So some kids develop the disease at 2, some individuals that develop celiac at 82. Why? There is such a variation. There are different organs and tissue that are involved. But the real deal that made it very clear that, yeah, genes are important, eating gluten is important, but not sufficient, are these prospective studies showing an increased prevalence over time. So here you see a couple examples of papers that were published that show that in the same individual followed over time, celiac disease doubled every 15 years. So there is a clear increase of the risk of developing celiac disease over time that is due to some elements that we didn't know until recent past, but now we know to be related probably to ecosystem in the gut, what we call the microbiome. And indeed, at the beginning, we thought, well, maybe the quality of gluten or quantity of gluten or breastfeeding or the time introduction are the elements that fuel these epidemics. The study that we did a while ago that was published by following a large number of kids, 700, from birth for 10 years, come up with no answers. Everything that we thought that was going to be responsible for this or prevented this turns to be incorrect. For example, breastfeeding, we thought that was going to be definitely protective against, celiac disease, and it made no difference. The timing and introduction didn't make any difference. The quantity did not make any difference. But gastrointestinal infections seem to have a problem, meaning that, again, it changed the ecosystem of the gut, what we call the microbiome, could be a responsible factor there. And the genetics, of course, we knew this already. When this perfect storm comes together, what is the clinical presentation of celiac disease? There are many ways to describe this, but the typical way is that we describe celiac disease in 3 different categories. The people with symptoms, so in other words, people that are visible, so the tip of the iceberg that I show you in this cartoon, because they go to the doctor, they don't feel well. These are the people that they develop symptoms can be related to celiac disease. But so they have symptoms, they have, of course, the genetic susceptibility, their antibodies, anti-Ttg are positive. Because of the tip of the iceberg, that means the vast majority of people with celiac disease, they are not in this category. A good chunk of people, they have what is called silent celiac disease. So they already have the damaged intestine. They already have the serology, but they don't have symptoms, or at least severe symptoms, to bring them to the attention of physicians. How this can be possible? Because the intestine is a long tube, and if you have only a small part of this damage, you may not have symptoms yet. And then there is what we call the latent celiac disease, in which, of course, you have the genetic susceptibility, the antibodies are present, so you already have an autoimmune response there, but the intestine is still normal, symptoms are not there. So the classical way that celiac disease was described, the typical kid, young kids, the ones that this fellow in the Netherlands was looking at, with the chronic diarrhea, failure to thrive, big belly, in other words, the malnourished kids, they look like malnourished kids, are a picture of the past. We don't see this anymore. So it's very rare that we see kids coming clinic with this kind of picture. Indeed, even if the inflammation in the intestine remains the lone mark of the condition, this disease can really change aspect many, many times. Most of the symptoms still are gastrointestinal. And one of the most frequent, symptoms that really appears is this recurrent stomachache, abdominal pain. And it's very much like irritable bowel syndrome. As a matter of fact, if you look at the scheme of, irritable bowel syndrome, there are, in yellow there, the category of gluten-related disorders, including celiac disease and the other 2 with allergy and non-celiac gluten sensitivity, that they clinically can present that way. And of course, there are other conditions that can mimic that. So differentiate, celiac disease for all these other conditions based on clinic is going to be tough because they overlap clinically, cannot be distinguished. So you can have, again, a lactose intolerance, you can have a bacterial overgrowth and so on and so forth, you will present the same symptoms. And if you compare the frequency of the symptoms between celiac disease, for example, and non-celiac gluten sensitivity, you see that they are very much, overlapped in terms of the frequency. Most frequently, though, we see more and more what we call non-gastrointestinal manifestation of celiac disease. So even if the inflammation starts in the gut, celiac disease can touch any tissue organ of your body, any. So the skin, the bones, the hematopoietic system, the liver, the joint, the brain, everywhere. So without going too much in these details, I want to just touch upon a few of them. For example, dermatitis herpetiformis is a very, very itchy skin condition that presents itself with this, vesicles that they break because of scratching. and in general, the elbows and the knees. Vast majority of people with dermatitis piriformis, they do not have GI symptoms. However, if you do the endoscopy, most of them, they have villus atrophy, but if you do the skin biopsy, it shows the classical signs of, deposit of these antibodies. Anemia is a very frequent way that disease presents itself. Actually, nowadays probably is the most frequent clinical manifestation of celiac disease. And with anemia comes, fatigue, because if you're anemic, you're tired all the time. Most of the time is due to iron deficiency. And of course, that's very intuitive, because if the intestine is damaged to the point in which iron cannot be absorbed, efficiently, you will develop anemia. And again, osteoporosis is another very interesting and very frequent way that disease presents itself. In general, we don't even know about it, because unless you have such a severe osteoporosis, you break your bones just walking, or with minimal trauma, you don't know. But celiac disease is the most frequent cause of premenopausal osteoporosis in women and osteoporosis in men at all ages. Short stature, it's another big problem that we see in kids, and is really clinically a worrisome presentation, because if you don't make the diagnosis on time meaning before that these kids that become, start puberty, you may eventually not have the capability of catch-up growth, and these kids will stay short. Gluten, among the other organs that are targeted, it really lacks the brain very much, for a reason that we didn't know until the recent past. Now we start to understand a little more about this gut-brain axis, so there is a communication. So people with celiac disease, because of inflammation in the brain that parallel the one in the gut. So in other words, these people, they have neuroinflammation. Depending where this neuroinflammation materializes in the brain, can develop anxiety, depression, ADHD, short memory loss, chronic headache, or ataxia, seizures, and schizophrenia, and all that. So it is very, very frequent that people with celiac disease will have any of this. Thankfully, most of the time, the ones they are, less severe, and they tend to resolve once going to gluten-free diet. Of course, I've told you the iceberg. There is an asymptomatic, group of individuals that, again, they have already the damage, the autoantibodies, but they don't have symptoms yet. These are the ones that we discovered thanks to the fact that we actively screen all family members when somebody developed celiac disease, or with comorbidities that we know they are very frequently associated with celiac disease. And then among the associated conditions, the one that I want to really focus on are, certain genetic disorders or syndromes like, trisomy 21 or Down syndrome, autoimmune conditions like, type 1 diabetes. And, I have some background noise. I apologize for this. Type 1 diabetes, I was saying before, thyroiditis, arthritis, autoimmune liver disease, and so on and so forth. So bottom line, there are some genetic disorders and some autoimmune disorders for which we actively look for celiac disease because of the comorbidity. The bottom line is that if you look at the healthy populations where the prevalence is roughly 1%, in first-degree relatives, it's 10 times more, and in second-degree relatives are roughly 4 or 5 times more. Now, the diagnosis, here has also been an evolving spectrum, and the more we understand the pathogenesis of disease, the more we have to do for diagnosis. And here, this is a table summarizing the current tests that are available. The bottom line by far, the most robust way to screen for celiac disease is the anti-Ttg antibodies. They are very sensitive and specific for diagnosis, much better than anything else that we have. The caveat is that they are IgA-based antibodies, so if you have IgA deficiency that is more frequent among people with celiac than the general population, they may test false and negative, in which case we use the IgG-based deamidated gliadin antibodies. And then we will take a look at why and when we do HLA in a moment, actually right now. So the HLA test, so the genetic test, is something that we don't do routinely. We know that, again, are extremely valuable not to confirm the diagnosis, because true, 95% of people with celiac disease, they have either DQ2 or DQ8, but so do 30% of the general population. So if you're positive, we can't tell if you have celiac disease or you are among the healthy individual who would never develop celiac disease. The value of doing the test is to rule out celiac disease rather than confirm it. So in other words, it has a very high negative predictive value, because if you're negative for HLA, DQ2, DQ8, the chance that you develop celiac disease is very, very low. And so we do this test again for asymptomatic relatives to decide if we need to continue screening them, people with genetic disorder associated with celiac disease for the same reason, such an autoimmune disease like type 1 diabetes, or for somebody that went gluten-free before doing the test, that of course is not reliable if you're already on a gluten-free diet, and therefore before you do the gluten challenge eventually, you may want to do the HLA to see if it's worthwhile to do the challenge or not. The diagnosis needs to be confirmed by an endoscopy. And this has been because, of course, you want certainty, given the fact that for the rest of your life, you need to be gluten-free. But there's been always an effort to see if you can avoid the biopsy, particularly in kids, because, you know, it's still a procedure. It's safe most of the time. I mean, say almost always it's safe, but it's still a procedure. The kids need to go under anesthesia and so on and so forth. So a few years ago, the European, Society of Gastroenterology, Pathology and Nutrition, developed a new algorithm that eventually will avoid the endoscopy. And this is, I know that this looks complicated, but I will make this simple. If you have symptoms suggested celiac disease and you test for the Ttg antibodies, and they're positive at high titer, 10 times more normal, and if you also test positive for this other test that is the anti-Endomysium antibodies, and you have the HLA compatible, so in other words, you have all the elements that you can imagine to be compatible with celiac disease, so 10 times more the Ttg, anti-Endomysium and HLA positive, you can confirm the diagnosis without doing an endoscopy. This is not frequently happening anyhow, because the vast majority of the time is, for example, that you have the Ttg positive and the M negative, in which case you have to do a biopsy, or the Ttg is not 10 times more than normal, and therefore you have to do a biopsy anyhow. So again, in very selected cases and under the supervision of a pediatric gastroenterologist, an endoscopy could be avoided, but not, on a routine basis. Definitely this does not apply to adults. Now, we use the Ttg antibodies for follow-up as well, but unfortunately, recent data suggests that while the Ttg antibodies is very robust for diagnosis, it's not as good for follow-up. And again, now we are dealing with issues that start to be extremely worrisome for us. So despite that people eventually go on a gluten-free diet, they are strict and so on and so forth, sometimes villus atrophy persists. And we start to really look into this because this can have consequences over time. And again, why the gluten-free diet was considered almost infallible in terms of efficacy, so in other words, to resolve symptoms and the inflammation in the gut. Now we have data that suggests that that's not the case. First of all, again, there is no really good correlation between the TTG antibodies and what happens in your guts once you go gluten-free. Long story short, based on the data that we have right now, you may have absolutely normal TTG and the gut is still inflamed, and vice versa. You can have the TTG that's still extremely elevated. You do a second endoscopy and it's absolutely normal. Why we have to really care about the persistent villus atrophy? Well, because more than the symptoms, the inflammation that doesn't go away is associated with morbidity, including increased risk of osteoporosis, of hypothyroidism, loss of weight with low body mass index, multi-nutritional deficiencies. There is a risk of increased cancer, but it's, I would say, rather rare, and the risk of other comorbidities like other autoimmune diseases. So in terms of mortality, there are mixed information out there, but all in all, there is, I believe, growing evidence that untreated celiac disease at least double the risk of mortality compared to a well-controlled celiac disease. So for kids, also there are problems like growth failure, nutrition deficiencies, of course, the fact that the school performance can be affected, including also other problems like peripheral neuropathy and so on and so forth. Why we have to look at this if there are no treatment options other than gluten-free diet, and when it fails, we can't do anything else? Well, actually, that's not the case anymore. Currently, there are at least two options for people that are non-responders, so non-responsive celiac disease. I'm not talking about refractory celiac disease or something else, but people that, despite all the efforts that they make, they are continuously exposed to gluten by accidental cross-contamination. One is a special diet that is called the gluten-contamination elimination diet. And the other options is use steroids. For example, budesonide, that is steroids that works only in the gut. But in the making, there are many other alternatives that I would very briefly discuss in terms of treatment complementary or alternative to the gluten-free diets. Indeed, what was unthinkable until the recent past. Now we do have a lot of insights of possible alternative to the gluten-free diet. One thing that I want to tell you though, if you see products in the market or Amazon or in the drugstore that say, oh, this is going to digest gluten, so take this and then you can eat whatever you want as a celiac, absolutely not. There is no such a thing. These treatments are not validated, and I will strongly discourage you to even think about it. The reality is that the gluten-free diet, unfortunately, is not 100% efficacious as we believed before. 30% of people with celiac disease, they have persistent signs and symptoms after a year of gluten-free diet, and more than 40% of the adults and roughly 20% of kids, despite good compliance, they still have damage of the intestine. One of the most challenging issues when you embrace a diet, any given diet, including the gluten-free diet, is proper compliance. And you know better because you live firsthand this experience that it's easy to say, very difficult to implement, particularly when you travel or you have to rely on somebody else in terms of the stringency of the diet. For kids, besides the same issues that adults they experience, like cross-contamination while traveling, vacationing, eating out, and so on and so forth, kids, they also have the unique challenge to compliance with gluten-free diet, including peer pressure, eating, sleepover and college life, and so on and so forth. And honestly, while, again, not only the gluten-free diet is not 100%, efficacious, it's also very poorly accepted. So in other words, people, they absolutely aesthetic and they are fine with the gluten-free diet. As celiac are only 25%. The remaining 75%, they are average, or they really have a poor or very poor, feeling about, being on this diet for the rest of their lives. And if you look very carefully, 70% of people with celiac disease, they are exposed to gluten. Very few they do intentionally, but there are the vast majority no intentional exposure, like 60% of those that eventually exposed, they know they are doing everything under the sun, but yet there's inadvertent exposure. So what are the pros and cons of the gluten-free diet? Of course, it's efficacious, but not on everybody, as we believed before. So there is a con there. It's definitely safe, no side effects, but socially difficult, sometimes impossible under specific circumstances to maintain good compliance. It's not pharmacological, so there is no drug involved in that, so that is a good thing. But that means that it's not covered by the health system, so the extra money that you have to pay for gluten-free products comes out of your pocket. It's self-prescribed, self-administered. You don't have to go to the doctor to have a prescription for the diet. But that means poor medical support, poor regulation. Some countries are better than others, but you have the risk to be exposed to gluten and you don't even know about it. Definitely as a pro, the gluten-free diet is the treatment for celiac disease. However, as a con, there is nothing else. And the gluten-free diet, as we mentioned before, is a life-saving, because if you don't go gluten-free, you will have increased morbidity and mortality. But again, there's a high burden of this treatment because people, they really are under stress when exposed to this. And, if you do a surveillance, a lot of people, they really, really want something else other than gluten-free diet. So the non-responsive celiac disease and refractory type 1, again, I told you what is out there. We're not going to talk about the refractory sprue because it's a totally different story. If somebody has a question later, we can discuss that. But, what are the indications to go on something other than just the gluten-free diet? So in other words, an adjunctive treatment. For those, again, that do not respond, again, refractory, they need a kind of different treatment that we're not going to discuss. The adjunct therapy could be used as a sort of safety net to protect against, accidental gluten exposure. And, in very specific cases, if and when we got there, can be an alternative to gluten-free diet. So a treatment that will allow you to eat whatever you want. For example, people with type 1 diabetes that already they have a restricted diet, and having a gluten-free diet on top of that is complicated. And then, of course, prevention. So we will discuss a little bit of what kind of treatment are now available. I'm not going to go through the details of the scheme. This is just to let you know that now we know a lot of why people with genetic predisposition, they develop celiac disease. Each of these yellow points, 1, 2, 3, 4, and so on, are possible point of attack for treatment alternative to the gluten-free diet. If you go on this site, that is the clinical trial site of the US government, where you have to register any clinical trial if you want to be published, or if you have an ambition that whatever you do would be once made available to patients, you need to register. There is an astonishing number of clinical trials registered for celiac disease, 260. Consider that, until 2005, 2006 were at 0. That's a pretty large number. And if we go through this scheme and we focus on the pharmacological intervention of this 260, 112, we're talking about drugs for the treatment of celiac disease. Where are these clinical trials done? A little bit everywhere in the world. The vast majority are done in the United States and Europe. There are different phases when you do a clinical trial. From the early phase, in which the only thing that you do is safety. So you give the drug to normal people, healthy people, and see if they are having any side effects. And then you move to phase 1, 2, and 3, in which there is an increased number of people for a longer period of time, in which the drugs are given to people with celiac disease. And, the phase 3 is the one that preceded then the commercialization. And as you see, the more you increase the complexity of the phase, the less trials are ongoing. right now, there's only one phase 3 trial, that if successful will lead to the first product for people with celiac disease on the market. Again, the same scheme that I showed you before, this was 2010. There were a few drugs here and there that were in development at different points of the attack. And this is after 10 years, many more. And again, I don't have the time to go through it, but just to say there are different mechanisms. Some are anti-inflammatory, some are aimed at completely dismantle gluten that cannot be digested by us. Some, they block the zonal permeability of the gut, making the gut less leaky. Some are, vaccines. That means they reprogram the immune system to tolerate gluten. The immunosuppressants are for refractory sprue, so I'm not going to talk about those. There are enzyme cocktails, inhibitor of the enzyme that started the chain of events that leads gluten to be offensive for people with celiac disease. Blockers of the genetics, the HLA, DQ2, probiotics, because now we know that the gut microbiome has something to do with that. And then finally, some gluten sequestration, some molecule that take gluten out and will not allow the interaction with the gut. Bottom line, the gluten-free diet is not as efficacious as we believed before. The burden is high. 60% plus of patients, they want something else in adjunction of the gluten-free diet. Probably the first agent will be safety net, and then hopefully, the future is going to be something that will be instead of, but we're not quite there yet. Of course, the ultimate goal is prevention. And here we start to have some good data in which we know what is the march that leads from genetic predisposition to the clinical outcome. And this is thanks to studies like this, in which we follow kids from birth, sometimes even before they are born. They are at risk for celiac disease, and we try to understand why some of these kids, they take the wrong turn and they develop, celiac disease, while others, they do not. And the long story short, now we know that, again, the microbiome has a great deal to decide who stays healthy or does not. It is because of the microbiome and the composition and its function that eventually some people, they take the long directions, and eventually we now have the capability, months before that these kids that develop the disease, to see which species of the microbiome, which pathways, which metabolites, they change before the onset. Those are possible targets for preventive intervention. And I want to finish by thank you again for spending, Friday afternoon, rather than go to the beach or having a great time, to listen to this, quick overview of the state of the art of celiac disease. Of course, I need to thank all my folks here that have been instrumental to help, producing some of the data that I share with you today. So I am open to any questions that you guys have. Again, you can, post the question, of course, in Spanish. I will respond. If I don't understand, I ask Carlos help for translation.
Okay, first of all, Dr. Fasano, thank you for a spectacular talk. I think it's been loaded with information. I'm sure the folks in the audience will start with some questions. I'm gonna sort of drill you with some of the questions that I hear from my patients as well. So you mentioned in your talk, there has to be symptoms. There's obviously genetics. Sometimes there's antibodies. The question is what to do when the duodenal biopsy is sort of very early stage, Marsh 1, non-specific. Is that confirmation? Is it not? Let's assume that the biopsy, it was well taken, there were multiple samples, it was well oriented, and the pathologist knows what he's doing. What to do when the biopsy is a little iffy?
So again, the deal breaker is the biopsy because it shows the autoimmune insult. But as I mentioned before, there are cases in which you are very early in the process. You already have the autoantibodies positive, genetically compatible. So, again, you have to do the HLA to make sure that, this is genetically compatible. And the people, they have already symptoms sometimes. But, the biopsy done the right way doesn't show the damage yet. These are what they call potentials. Now, in the past, in Sweden, actually in Finland, they have done an experiment that I believe that ethically cannot be done anymore. They took these patients and they split in two groups. One group that went gluten-free and the other one that was left on a regular diet. The one that went gluten-free, the symptoms improved and resolved. The autoantibodies went away and therefore they stayed on the diet. The ones that were left on a regular diet were rescoped, and 100% of them within a year had the enteropathy. So all this to say, if you have symptoms that are compatible, if you have the serology is compatible, if you have the genetics compatible, and you ruled any other possibility for the symptoms, that's the other thing that's important. There would be a travesty if you make somebody gluten-free and maybe that this individual has IBS or Crohn's, whatever. If you are, in other words, done everything under the sun and there is no other answer, these potential celiac disease are the ones that should be on a gluten-free diet. If the symptoms are severe enough to affect their lifestyle, if they are, I would say not that severe, it would not be totally inappropriate to wait a little bit longer to see if the antibody stays high, if the symptoms will get worse, will stay the same, or will improve. And if the story goes worse, to repeat an endoscopy, and again, most likely you're going to see the damage at that point.
So going deeper onto this same sort of line, so you have symptoms, you have genetics, but the antibodies are negative, and the biopsy is very early. So two questions here. Are there other antibodies? There are some publications, maybe in the alternative medicine side of things, where more antibodies might be somewhat predictive. What do you have to say about those?
No, again, many years ago, we published the rule of the 4 out of 5, so to speak. So now the 5 issues are symptoms compatible, genetic compatible, the HLA compatible, the biopsy compatible, resolution of the symptoms, and the antibodies go back normal once you go on a gluten-free diet. Okay. You may have, vast majority of people, they have all 5, okay? But it's acceptable that you miss one of the 5. So okay. In other words, we know that even 1%, but you can be genetically HLA, DQ2, DQ8 negative. Rare, but it's possible. We know that, you can be serology negative and still you can have the condition. We just discussed the biopsy may not be normal and you have celiac disease. And of course, you can go gluten-free and the symptoms will not resolve right away. But now you talk about 2 deal breakers. The biopsy is not there and the antibodies are not there. There are no alternative to the autoantibodies for the diagnosis of celiac disease. So you need to have either the TTG and or the anti-Nemesium and or the diamidated anti-Gluten antibody. In other words, the next generation, not the original anti-Gluten antibodies. Those 3, TTG, anti-Nemesium, and diamidated, they are all autoantibodies. They look at the autoimmune disease like celiac disease. One of the 3 needs to be positive.
So some questions from the audience. Dr. Canton asks, could you speak a little more about other forms of dermatitis? He mentions here atopy or Tourette's, and then he also questions, or something I just mentioned was the importance of the pathology, being properly assessed and sometimes verified by a second pathologist. Could you comment on that?
Sure. So the typical skin manifestation of celiac disease is dermatitis and crediformis. DH is the skin manifestation of celiac disease. So if you diagnose somebody with DH, there is absolutely no doubt that he or she has celiac disease. However, you can have other, manifestation of skin manifestation of celiac disease, including, atopic dermatitis. But again, you have 25,000 other reasons why you can develop atopic dermatitis. So that is not pathognomonic anymore. It's not that it's for sure. You have to put a skin lesion direct toward, again, atopic dermatitis or seborrheic dermatitis in the context of other symptoms, in the context of the autoantibodies, in the context of a biopsy, and so on and so forth. So it's less, pathognomonic. When it comes to the biopsy, again, you mentioned this already, so I'm going to repeat what you just said. You need to be wise that you take multiple biopsies, because sometimes the gross appearance of the intestine doesn't reflect the macroscopic appearance. So you can see something that just absolutely look great, all pink, and you do the biopsy, there is complete destroyed intestine. And conversely, sometimes you see extremely inflamed intestine, you do the biopsy, the histology doesn't show any damage whatsoever. Then the orientation is important, of course. If you have, a good oriented biopsy so that you have the villi that are cut, through their axis, now you can really interpret that. But if you cut transversely and you look at the top, now you have all circles and you can't make the hole. And if there's any doubts, a second eye by a second pathologist is always a good thing. And honestly, I personally review all the biopsies and I do that blind. That would be also very important, so that the pathologist is not biased by the clinical information and say, oh yeah, this fellow has a TTG of 300 and therefore gotta be positive, and make the call that maybe it's not correct. And vice versa, of course.
Question about Lara Hudi asks, genetics are positive, there's thyroid disease, but the biopsy and antibodies are negative. So this patient carries significant risk. Is there anything to do for prevention? You teased a little bit on your title that you were going to talk about prevention. And we know we're running on 1 hour time already. But if you can talk about that. So
that's a very good point. Again, we now know, because we've been following people over time, that you can eat gluten for 50 years and then all of a sudden there's something that's, turn the switch on and you eventually break tolerance and you develop the problem. Now, the people, they have pathologies like Hashimoto or other autoimmune disease, they are in strong association with celiac disease and may be symptoms, and they are genetically compatible. Again, is that possible that these people down the road will develop celiac disease and you can do something to prevent it? Right now, we cannot. And the reason why, because we don't understand yet what makes the switch to go on. But I am very confident that we will in the near future. The study that I mentioned before, the CDGEM study, is aimed indeed just at that. Without going too much into the technicality, we know that the reason why you switch from genetic predisposition to clinical outcome is the consequence of the epigenetic pressure, so that changing the expression of genes that I show you through the organoids that will be turned on and off, that will make the immune system now to not tolerate gluten anymore. Once we understand which component of the microbiome will make the switch, now we have a target. And if we know, as from this study, we know that there are changes that precede months this switch. Now you can intercept the disease before that happened. So, again, this is our aim. This will take a huge amount of data. This will take artificial intelligence and mathematical modeling with deep machine learning to do the modeling so that we know which target to go after.
I think I have a couple more questions to finish off. One is someone asks about stress, and I'm going to link stress in celiac disease together with sonulin as a pathway. So sonulin is overexpressed in celiac disease. Is there any relation with sonulin with other diseases? Does stress play a factor? Is it through sonulin, etc.?
So again, we didn't have the time to go in these details, but besides genes and environment, there are at least another 3 elements to develop any chronic inflammatory disease in humankind, including autoimmune disease like celiac disease. The third element is the loss of barrier function, the ones that keep the enemies, in this case gluten, at bay, outside our body. So if you have the gates closed, gluten can't come in. Is you loosen up, it comes in, and zonulin so far is the only mediator of permeability of the gut that is known. And therefore, you have to have an increased zonulin level to have the chance to develop celiac disease. So much so that the phase 3 trial that I was telling you about is all based on a zonulin inhibitor that closes this gap again, so that doesn't allow gluten to come in. The fourth element is an immune system that is hyperbelligerent, fights much more than it's supposed to do. And the fifth, I mentioned already, is the microbiome that changes composition and function. I just artificially put this out there, but they're highly interconnected. So an increased gut permeability makes the immune system hyperbelligerent. The immune system is hyperbelligerent will make the microbiome to be imbalanced and so on and so forth. Why this stuff happen? There are many, many stimuli that can change the zonulin production of the belligerence of the immune system and so on and so forth. One of them, probably the top of the list, stress. Stress can definitely do major damage to this very tightly controlled equilibrium to keep everybody in check. Matter of fact, it's well described that stressors, infections, ATRIP, physical or emotional threat, pregnancy, surgery precede the onset of celiac disease, because this, very balanced, interaction with these elements is put off balance by stress. So that was a long way to answer the question, including the zonulin part about stress and the zonulin role. Of course, zonulin has been linked to many, many other chronic inflammatory diseases. The list is long, but metabolic disorders, infections, COVID-19 now has been associated to zonulin. Just published, 3 days ago, a paper on that. Neuroinflammation, so schizophrenia has been associated with that, cancer, and so on and so forth.
Okay, last question, sort of related to the times. COVID. Is there a registry that has followed patients with celiac disease, both symptomatic or in remission, in COVID times? Is there more disease?
So there been some, surveillance on the matter, because, there were 2 questions that we were really focused on. Do people without immunity be a higher risk to contract COVID and pay consequence in that? And the answer is no. It looks like that people with celiac disease, particularly the ones that are under remission following the gluten-free diet, they end up to have the same risk of any other people to contract COVID. So that's good news. Bad news, the opposite is the COVID-19 infection increase your risk to develop autoimmunity? And the answer is yes. There is an increased risk, including celiac disease, to be triggered by this infection. And once again, this goes back to what we were saying before. An infection, a stressor, may put you over the edge.
Okay. Last question. This is the 3rd time I've said it, but this is the last question. Okay. Sonulin. Do you test stool, serum? Do you test regularly outside of celiac disease?
So, this is a work in progress. I know that commercially available, there are both tests for serum and stools. I've seen much more in the literature of serum, so those data seems to be more robust. There's a lot of confusion about this ELISA because, you know, there is question what they are measuring, but, you know, zonulin mistakenly is considered to be one single protein, is a family of protein. They're all related together. They all do the same thing. But, you know, some of these kids, they measure more of this member, the zonulin family, rather less, and so on and so forth. And they've been, again, linked to a variety of conditions way beyond, you know, celiac disease. And you know, I'll give you only one example. Again, as I told you, kids with COVID-19 that develop a severe complication after COVID-19, what is called the multi-organ inflammatory syndrome in kids, they have increased level of zonulin. We use that as a biomarker to know which of the kids with COVID-19 infection may go that way to try to see if we can mitigate the problem. And these are also the kids, at least, you know, the proof of concept, this paper, that if you give the larazodide, the blocker of zonulin, these kids will get better because the leakness of the viral particles from the gut into the bloodstream is stopped. And with that, the cytokine storm does not act. This is in one simple example to say this is a generalizable mechanism that is not typical of just celiac disease, but any chronic inflammatory disease that will imply a loss of control of antigen trafficking from the external environment in our body.
So blocking the tight junctions is in the near future.
It's in phase 3 for celiac disease. We hope, we all have finger crossed that would not fail. And if commercially available for celiac disease, I'm confident that other conditions will be tested for the same kind of mechanism.
Well, Dr. Fasano, I know Rocio and Kathy will have something else to say. I want to personally thank you. I want to thank Maureen Leonard, who's in your team, for being your face in Twitter. She shares all your knowledge and all your research. So I want to thank you for that. And I'll hand it over to Rocio and Kathy.
Thank you, Dr. Vitali. This has been a fantastic webinar by Dr. Alessio Fasano, which enriches with everything that we actually need to know about all the advancements on celiac disease, which is an enigma sometimes for patients that has to pass through that and have different specialists to look after us before we get to a conclusion of diagnosis. So basically, we really like this participation. We hope you can come to Panama soon so we can see you in person and you can be here with us. And I'm really glad to be here in this panel, to be with my gastroenterologist here in Panama and also my gastroenterologist that diagnosed celiac disease for me in Boston. So for me, it has been very, very pleasant to be here with you guys. And also I want to recommend the book Gluten Freedom. Gluten Freedom is a book that Dr. Fasano did a couple of years ago, and it's very easily to read. I have recommended on my page, Ladies in Gluten, many times, but I cannot stop recommending it. It's not in Spanish yet, but we're working on it. So we'll see if we can get the publisher to get it in Spanish, even though it has been translated to many languages. Dr. Fasano also, for the medical people that are here, has delivered another book that is called Gluten, Gut. It's got the
gut feeling.
Gut feeling in the microbiome, and you can access it on Amazon as well. And it's more technical than the first one, but gut feeling, it should be also answers for medical experienced people that wants to learn more about celiac disease. So Dr. Fasano has done a very good research, and you can look at him at Mass General Hospital in Boston. I guess you're still taking consultations, right?
Yes, I do.
So basically, you can find him over there and follow him and all the different research that he has done. So I'm really glad to have you here once again, and thank you, Carlitos, for being our moderator. Fantastically done.
For myself, Dr. Fasano, it has been like an honor being here with you, sharing with you this webinar. Also, I want to thank you because all this information that you have to be shared with us is like gold for us, for all the persons who are here. So some of us were patients, others are medicals, and we are very grateful with you. para ustedes, querida audiencia, muchísimas gracias por acompañarnos, por quedarse un poquito más de una hora, por hacer las preguntas. Esto ha sido creado solo para ustedes y por ustedes. Espero que haya sido de gran valor educativo, de gran valor para ustedes y que sigan aprovechando de todo este ciclo de webinars. El día de mañana vamos a terminar el mes de mayo con la exponencia del gastroenterólogo, del ginecólogo Ricardo Ponce. Y nada, thank you very much, Dr. Fasano. God bless you y nos vemos en la próxima.
Muchas gracias. Hasta luego.
Good luck. Thank you.
Gracias. Gracias.